Today, my topic of presentation is H.pylori infection. Being the most common infection so far globally, we will discuss three important things about this infection, as most of the people among the physicians as well as surgeons also deal with this infection in everyday bodies. So that's why I choose this topic. Since I was not on list of presentation, this is actually a roster I have put deliberately to show you all, because we usually follow this roster. So in this roster you can see because orthopedics done, and because of some emergency Dr. Khalil is not here. So next was cardiology and gynecology. So both these departments refused because of not preparing the presentation. So that's why I have to take the turn. So my humble request to all of you is, especially the departments, is that kindly select your topic before 5 days before the presentation on Monday, and submit it to the coordinator, Dr. Umar, so that we will be easy to manage it accordingly. So sometimes, most of the times, in emergency, we have to proceed that night. They call and we have to make the presentations. So this was the roster. My topic of presentation is H.pylori. H.pylori infection still one of the most common chronic infections. So today we will talk a bit about the H.pylori infection. So the credit goes to these two great personalities who first ever discovered, isolated this bacteria in 1982. Robin Warren and Barry J. Marshall were the two personalities who isolated the bacterium from peptic ulcer patients first time, and later demonstrated the eradication of the infection with bismuth and early with either amoxicillin or tinidazole. So in 2005, because of their great work, both guys received the Nobel Prize for the great work. So this is a picture while Warren and Marshall won the Nobel Prize for discovery of this bacteria. So history is that in 1987, the Sydney gastroenterologist Thomas Brody invented the first triple therapy for the treatment of duodenal ulcer. In 1994, the National Institute of Health USA published an opinion stating most recurrent duodenal and gastric ulcers were caused by H.pylori and recommended antibiotics be included in the treatment regime. The genetics of H.pylori later on was transformed in 1997 by the publication of the complete genome sequence of H.pylori strain 26695, isolated in the UK in early 1980s. So why H.pylori is so important and why it is most common globally? Globally 50% of the world population is affected by this bacteria. So this bacteria's infection is so common globally, and particularly in East Asia, this is the most common infection. In China, you can say it's almost 43% common. Similarly, in Japan, it's among 37 to 41. And in South Korea, the prevalence is almost 42%. If we talk globally, its prevalence is more than 30%. But East Asia is most common and most affected regions globally. So that's why all the guidelines so far set by these countries because of high prevalence. Particularly, the conventional triple-based regime was first introduced, and later on the guidelines are set by these countries. And in recent years in China, because of high resistance to clarithromycin, they tried the Smith salt and they set the guidelines accordingly, and they get good results. Particularly in Japan, since the introduction of the new drugs which we call PCAB, potassium competitive acid blockers like vonoprazan, so they introduced the vonoprazan first time and they set the guidelines. Similarly in South Korea, because of the high resistance and high prevalence, they introduced the molecular techniques on base of erythromycin, and they set the guidelines. So the most affected region is the South Asia, and our region is also affected. Particularly India is mostly commonly affected countries in the world. than our country and rest of the developing countries. H.pylori is basically a gram-negative spiral rot, unipolar flagella, micro aerophilic, urease polypen. This is the most important character of this bacteria. You can say this is the picture of the H.pylori bacteria having the shape like this. So we talk about the globally the incidence per 100,000. You can say this is the most prevalent part. You can see there is 11 per 100,000, then 7.4, then 5.2, 3.2, 3.5, and no data. But this is also very less data. No recent studies showed that this incidence is increased to 23 to 25. Even some countries it's 25 per 100,000 incidence. So it's very high prevalence. You can see. Developing countries, this is the graph showing the incidence prevalence in developing countries, and developed countries have get rid of this bacteria to much extent because of good hygienic conditions and other measures they have taken. But still, you can see the graph is going high and high in the developed countries. Few infections occur in childhood and gradual increase in prevalence with age. 20 to 30% by 20 years and approximately 50% by 50 to 60 years. Of those, approximately 1% per year develop duodenal ulcer. One third eventually have peptic ulcer disease. 70% of gastric ulcer causes colonized with H. pylori. Low socioeconomic status predicts H. pylori infections. So the patients who develop the gastric or either duodenal ulcers, majority of them are affected by the H. pylori infection, or the cause of these ulcers is H. pylori. So developing countries acquire early in childhood with infection rate 50 to 60% by age of 10 and 90% in adults. Most adults infected but remain asymptomatic. In India, 70 to 90% of patients with duodenal ulcer have H. pylori infection. So the prevalence is high in India. Transmission is the route of transmission. You can see in this diagram. It's gastro-oral fecal route. Gastro-oral fecal route is the most common. Then the oral route includes sharing the utensils, free mastication of food for infants, family clusters, heterogenic and occupational. So these are the main route of transmission is fecal-oral. Dynamics of H. pylori infection, you can see in this diagram. This is the flagella, bacterial motility and chemotaxis to colonize the under mucosa. This is the flagella of the bacteria. And then it releases echotoxins, vacuolating toxins, we call gastric mucosa, that causes the gastric mucosal injury. Then this few secretory enzymes, mucinase, protease, lipase, gastric mucosal, they cause the gastric mucosal injury. And as you know, this is the urease producing bacteria, so it utilizes gastric acid. Gastric mucosal injury is caused by the ammonia after colonization. So lipopolysaccharides adhere to host cells inflammation. Outer proteins, they also adhere to host cells, and there are four secretion system. It is the pili-like structure for injection of effectors. This is the host cell. You can see the effectors. These are some molecules, KA, etc. Active remodeling, IL-8 injection, host cell growth, and process inhibition. So all these are the dynamics how this bacteria interferes and affects the gastric mucosa while doing all these chemical hazards to the gastric mucosa. Pathogenesis, you all know this, the normal mucosa is how the normal mucosa is affected. This is the mucosal barrier, damaging forces. The two most common damaging forces, gastric acidity and peptic enzymes. The mucus is here, the mucus layer. Then is the mucosa, muscularis mucosa, and submucosa, the layers. They are affected by the bacteria. As we previously discussed the forces. Defensive forces include the surface mucus secretion, bicarbonate secretion into mucus, mucosal blood flow, apical surface membrane transport, epithelial regenerative capacity, and elaboration of prostaglandins. So these are the defensive forces. So how the injury is caused? H. pylori infection, the most common cause, then NSAIDs, aspirin, cigarette smoking, alcohol, gastric hyperacidity caused by various factors, duodenal gastric reflux. So these are the factors that cause the injury. So increased damage or impaired defenses. Few other factors: ischemia, shock, delayed gastric appetite, and pause factors. These are also contribute. These both factors contribute to the injury of the mucosa. So when any of them causes increased damage or impaired defenses, then you can say this is the MH, the necrotic deafness, non-specific acute inflammation, followed by the granulation tissue and later on fibrosis, and then ulcer formation, and after a few years it can convert into cancer. Indications of H. pylori, H. pylori testing. So this is very more important to know all of us that nowadays majority of we people, doctors, prescribe H. pylori infection, H. pylori testing to each and every patient, regardless of indication. And not only physicians and doctors, rather some non-doctors also prescribe H. pylori. So majority of the patients who come to us in OPD, they have taken H. pylori medication or they have got testing before they come to us. So this is very important to know about the indications. Either each and every patient should be tested or it is a screening tool. The health is absolutely not. It's not a screening tool like that is B and C. But we have to segregate the patients accordingly. Either this indication is to test or not. So let's see what are the absolute indications. If there is peptic ulcer disease, if there is any history of peptic ulcer disease, if low-grade gastric mucosa, ulcerative lymphatic tissue, marked lymphoma, dyspepsia, undergoing upper endoscopy, initiating chronic NSAID use despite thorough assessment, unexplained iron deficiency, anemia, ITP, and past history of endoscopic resection of early gastric cancer. So these are the absolute indications we have to keep in mind before we advise the H. pylori. So any of these conditions the patient comes with, we have to advise the H. pylori testing. Relative indications: uninvestigated dyspepsia and younger than 60 years, non-endoscopic testing, low dose aspirin usage over a long time, patients who require long-acting PPIs for GERD, patients who are immediate relatives of stomach cancer patients, idiopathic thrombocytopenic purpura. So this is the most common indication. We people advise H. pylori testing, as here we mostly see the peptic ulcer disease patients are the patients with history of peptic ulcer disease. So these are the most common patients who require long-acting PPIs, who take long-acting PPIs for GERD and their symptoms are not resolved. So we usually, before going the endoscopy, we usually advise the H. pylori testing. Sufficient evidence for H. pylori testing: no history of PUD and typical GERD symptoms, insufficient. So insufficient evidence. If patient comes with these points, then we can say that H. pylori testing is not mandatory. Asymptomatic with a family history of stomach cancer, lymphocytic gastritis, acne, rosacea, and chronic urticaria, hyperplastic gastric polyps, and hyperemesis gravidarum. So these are the conditions we can spare the patient prescribing the H. pylori testing, because the evidence is insufficient. So we can initiate some tests in these patients, but the rest of the indications are not very quite sufficient to test to prescribe the H. pylori testing. So diagnosis is very important to treat the patient after fulfilling the indication. So we have the two set of tests. One is the invasive test and other is the non-invasive test. Invasive tests include the specimens. We usually take the endoscopic biopsy, usually duodenal biopsy, then the gastric juice, blood, liver biopsy, rarely. So blood and liver biopsy is rarely used because the main place of the bacteria is usually in the gastric mucosa and in the liver mucosa. Mucosal microscopy is bacteriology and histopathology. Then we can do the culture, urease test, and molecular test. So these are the invasive tests. A specimen, you can take the biopsies, two from antrum and two each from anterior and posterior corpus. This is the recommended. Usually we take two biopsies from these persons. This is the normal anatomy, and we can take two samples from each part. Then the histopathological diagnosis, we have gram stain, Jameson stain, working. So these are the particular stains used for the isolation of this bacteria. Histopathological diagnosis, you can say this is the most notorious picture most of the time asked by us in the part 2 examination. So I remember in my first examination, this was the slide put on in a talk station. So we have to, this you can see, this is the bacteria, H.pylori. So this is the famous histopathological picture of H.pylori. And similarly here you can see scattered H.pylori here in this stain. Histopathological diagnosis again is identified on gastric biopsy. Some particular stains are also used. Silver stain is the most common working stain. You can see the bacteria scattered here. So another test nowadays being used in our part of the world is the flow test, or a piece of gastric mucosa placed in a small well. A flow means the Campylobacter-like organisms. So the presence of urease is an indicator for the presence of H. pylori. The color change from yellow to, you see this is the, and yellow means negative. If the color changes to this one, it means pink. It means the flow test is positive. So the flow test is being done during the endoscopy. We took a piece and put on, and we can see if the color changes, the flow test. Its sensitivity is more than 90%. So this is the mechanism we do by this way. A non-invasive test we usually practice is the urea bread test. Nowadays available here, most commonly used. Stool test, culture, PCR, detection of antigen, and detection of antibodies, sera, urine, and saliva. Mostly we did here is the serum antibodies, and then followed by stool test. As the urea bread test is not available here, so we have to send the patient to long country. Urea bread test, this is the mechanism. We give a bread to the patient, C13 urea, it converts into urease. Then we collect the sample after 30 minutes. Again we test, and if the urea bread test is positive, then it's the strong test is having sensitivity and specificity more than 90%. A comparative analysis of the diagnostic test modality, what are the advantages and disadvantages? Endoscopy with biopsy is the most reliable test. It permits detection of pathology, allows detection of ulcers and neoplasm. The disadvantage is it is invasive. Sometimes the patients can't afford this, it's expensive and time consuming. Culture permits determination of antimicrobial susceptibilities and pathogenic features of isolates. Sensitivity is 77 to 95%, specificity is 100%. So no optimally sensitive in most laboratories. The disadvantage and time consuming. So culture is not usually being done in routine labs. So we have to send the specimen to a particular lab doing the culture. So unfortunately not available here in our labs. Histology allows direct visualization of organisms and extent and nature of the tissue involvement. 99 to 98% is sensitivity and specificity is more approximately 98%. Disadvantage is that gastritis may be patchy and biopsy may be performed on wrong area. Site selection could be the cause, and insensitivity to detect small numbers of organisms, time consuming. So usually this is the best test we can do, but because of these factors we usually avoid. So the rest of the test we can do is the flow test we discussed earlier. Then we have the pyloritic strip test. Serology is non-invasive, rapid, can be used as epidemiological tool. Sensitivity is not more than 95%. So similarly, urea bread test is also non-invasive. It's rapid, but its sensitivity is up to 95%. Involves expensive instrumentation or administration of radioisotopes, more invasive, and it's also costly and can do this test by doing the endoscopies. So these are the usual tests we can do. So to run TN test, we usually recommend is the HPSA, routine diagnostics, FM12 lab. These are the laboratory techniques. So the sensitivity is again 97%, and but impact of bowel movements has not been studied. Preservation of the specimen needs to be studied. So few factors can also interfere with the results, like the specimen sample time and bowel movements of the patient. These are also another factors. PCR methods not easily, not necessarily viable to bacteria. Assess H.pylori state, differences include antibiotic resistance. Sensitivity is 90 to 100. Sensitivity is 96% up to, and specificity is up to 100%. So PCR method is the most reliable, but it's again costly. Recommended treatment strategies. We all almost know about the treatment regimes and treatment guidelines. The first line therapy, we all know it's a PPI plus clarithromycin and amoxicillin, or PPI plus clarithromycin, or if someone is allergic to amoxicillin, we can use metronidazole. This is the conventional 3-drug first line therapy. If this therapy fails, because of we earlier discussed the clarithromycin resistance is very high, so we use the second line therapy, includes PPIs plus bismuth 120 mg QID, metronidazole 500 mg TDS, and tetracycline 500 mg TDS. Or we can use PPIs, metronidazole plus tetracycline. These three can also be used, or if we use PPIs, metronidazole plus amoxicillin. So amoxicillin, tetracycline plus adding the bismuth. This is the quadruple basically therapy, which we call second line. Still, if this therapy fails, then we have the third line therapy, is the empiric rescue therapy, or treatment tailored to individual antibiotic sensitivity. So we can change the clarithromycin to levofloxacin. One is the levofloxacin based sequential therapy, another is the metronidazole based. So we can try these regimes also. Plus we have another regimes nowadays. There is the hybrid therapy or sequential therapy. One is the levofloxacin based, and another is the it is basically 10 days therapy, 5 days each, using these two drugs. Guidelines from Pakistan. Here you can see the treatment options. Clarithromycin triple. We have proton pump inhibitors, PPIs plus clarithromycin and augmentin 1 and amoxicillin 1 gram, the most commonly used therapy. Quadruple we discussed earlier. Then the sequential is the I earlier talked is the proton pump inhibitors plus amoxicillin 1 gram BD, proton pump inhibitors, clarithromycin plus 500 mg, nitroimidazole twice daily for 5 days each. Then we can use proton pump inhibitors, 1 gram amoxicillin BID plus 500 mg nitroimidazole plus 500 mg levofloxacin. So one is the 5 days with clarithromycin, and next 5 to 7 days with this nitroimidazole. So this is basically levofloxacin based sequential therapy, or clarithromycin based sequential therapy. The guidelines show the few guidelines show the low clarithromycin resistance. In these patients, clarithromycin containing triple drug therapy. Alternative is the bismuth containing quadruple therapy. Second line is the bismuth quadruple therapy or levofloxacin. We can also add guided by antimicrobial susceptibility testing whenever possible. So when we apply these two therapies or three therapies, but still if there is resistance, we can do the resistant test to check the next antibiotic suitable for this therapy. High clarithromycin resistance, we all know it's recorded, so that's why we usually nowadays use levofloxacin. So triple drug combination of PPI, clarithromycin, amoxicillin or metronidazole. So then we replace again with bismuth. So these are the basic therapies. The 4 or 5 regimes we usually use. Number one is the triple based therapy. Next is the sequential levothyroxine based or clarithromycin based. Then we have the bismuth based for triple therapy. Then the last one is the hybrid therapy. Here we use the 14 days regime. The first 7 days we use amoxicillin plus PPI. The next 7 days we use imidazole plus clarithromycin. So this is the new therapy. According to the resistance and patient to patient, we can change these therapies accordingly. But this is very important. If once you have given the regime to a patient, again the patient comes with the resistance, then you have to change the next regime accordingly. As most of the patients you have seen, they take the same regime twice, thrice. So this is not the good option. The roles of probiotics. So I think this is the last slide. I think nowadays probiotics can be